Welcome to this peer-to-peer session brought to you by Rayner. And it's a great pleasure to be able to be here this evening. I'm in the UK for the Ridley 75th year celebration of the anniversary of the first intraocular lens. But the topic today is another intraocular lens, something of interest to many of you, and particularly to myself, as this is a lens which I developed with Rayner, but also to our guest this evening. And Alastair Stuart is one of the UK's leading cataract and refractive surgeons, also the Medical Director of Optegra. And he has used this lens quite widely and successfully. So I'd like to introduce Alastair and tell you, Alastair, that I'm really pleased to be the host to ask you many questions, because I'm always fascinated how different surgeons approach this lens.
Sure.
So we're going to touch on quite a few things, if you'll allow me to.
Of course.
I'd like to, number one, understand how you use this lens successfully, the type of patients that you consider candidates, broach the subject of what about patients who've had previous refractive surgery, try and understand how you utilize Monovision and what level you use, and then in all fairness, give you a chance to ask me some questions at the end. So I'll start off, if I may, Alastair, and you've used the lens widely, so you must have developed an approach. I'd like to understand from you, do you identify a selected patients? What are your criteria for using it? How do you explain that to the patients that you think would be good candidates?
Sure. So the majority of patients that come to see me at Optegra are coming privately, so they immediately are patients that are looking for some glasses independence. That's what they're coming for. And so the first step for me really is to ascertain the patient's expectations and what their motivations to surgery are. And so really that centers around how much glasses independence they want. And so if they are happy wearing reading glasses, then the EMV for me is a perfect solution to offer an emmetropic target. So just giving plano in each eye and explaining to the patient that's going to give them the best possible distance vision that they can achieve unaided. But then it will also give them some useful intermediate. I explain to them that they're going to need reading glasses on a daily basis, but they're going to get a lot of extra than they would with a standard monofocal without taking any extra risk. There's no added headache. I don't have to worry about halos, problems like that. If I want to try and get a little bit more out of them, if they're looking to also be independent of reading glasses, then I broach the subject of multifocals and Monovision. I do think that the greatest independence comes from a multifocal in terms of glasses independence. So the patient is really motivated towards not wearing glasses at all, then I'll talk about multifocal, but then I have to counsel them about all the downsides. The contrast, sensitivity, the fact that there's going to be a compromise in image quality, night vision problems. So in my head, I'm actually leaning towards Monovision for them, because as the surgeon, in my mind, I'm thinking about the worst case scenarios. And the worst case scenario with a multifocal, if you do good surgery, is that they don't tolerate the lens. And that leaves that patient in a difficult situation because there's no easy out. Whereas for me, with Monovision, the worst scenario if the surgery goes well is that they don't tolerate the Monovision. Well, you can reverse it. So I have the ability to offer LASIK or Sulcaflex lenses, secondary procedures to then take them back to plano-plano. At the end of the day, that would just leave them in reading glasses. So we've got a way of reversing it, and that gives me a lot of relaxation around it. It helps me sleep at night. I don't worry about those patients as much because there's an easy out for them if they don't tolerate it. But the fact is that the vast majority do. 98% of patients, in my experience, will tolerate Monovision. A lot of it is counselling, as we'll talk about later, I'm sure. But my first step is to ascertain what their expectations are and what their motivations are, and then work out which of those scenarios suits them best.
Yeah, I mean, that does make sense. And I do think there is a place for the full range versus perhaps the intermediate or with Monovision. Personally, I don't offer them that full range, and I tend to depend on the Monovision if they do want that spectacle dependency. You've got to be very careful with spectacle dependency. Even if you're using a full range, of course, you never promise them.
Absolutely.
So
The golden rule
never
is under promise and over deliver in this.
Absolutely. And I've always found that with modest monovision, and now with the introduction of EMV, I can actually over-deliver, and it comes down to the target, doesn't it?
Sure.
And it's interesting, as I've seen EMV enter the field, how people say, yes, I do use monovision. I say, well, how much do you use? And they say, well, minus a half. And then they creep up to about minus 3/4. But I still see a reluctance to go beyond, say, minus 1.25. I've used monovision widely for many, many years, over 20 years, and my magic number was always minus 1.25. Maybe minus 1.5 for the high myopes,
sure.
But otherwise, because that's the threshold where you start perhaps impacting on things like stereo and bilateral contrast. But when you're using something like EMV, so I'm very happy to do the same, at least minus 1, because I know your level of spectral independence just ramps up as you do it. And I was thinking about it the other day, and I came up with the words, what does EMV add to monovision? Because it does add. And I call it more for less and less for more.
Sure.
And I use those words because for that same level of myopic defocus, you get more. But for that same level of myopic defocus, yes, you get more reading, but you get less impact on distance, and you get less impact on stereo and other things, because you're at the threshold at minus 1.25. But when I watch the numbers, it's slowly increasing. People are drifting towards a bit more myopia to the minus 1, minus 1.25 range, but still somewhat slowly. So I'd be fascinated where you are on that spectrum.
Well, we're all influenced by our previous experiences, aren't we? And I think that's where this comes from, is I think a lot of surgeons out there that have tried standard monovision, as I'd refer to it, with standard monofocals, have had problems because the tolerance is low. About 2/3 of people, I think, tolerate standard monovision. And there's problems with intermediate because nothing's covering that. Stereopsis, there are downsides to it. But what bringing spherical aberration into the system does is it doesn't have those same trade-offs. By incorporating spherical aberration into the system, you are improving on those pitfalls. And so my experience was, before I got involved with the EMV, I'd done a lot of Presbeyond, which is the laser platform for a very similar method. It's the same principle. And so that gave me an awful lot of confidence, because our standard monovision setup for Presbeyond would be minus 1.5, minus 1.25. So that gave me the confidence to just go straight in at that level. I didn't have to work my way up and test the waters. I knew that they would tolerate it, and they have. And so that's my target straight away, is that I will generally aim for minus 125, minus 150. We do testing on patients beforehand. So all patients that we consider this for will do LBV testing, we call it, laser blended vision, blended vision testing, seeing how much an isometropia they can tolerate. Now, sometimes that gets difficult in the presence of cataract, for example, but we will still do the testing to give us a flavor of how well that patient's going to tolerate it. And occasionally you find people some surprises, for example, reverse dominance, things like that. So it's important to go through all those, but my general target, if you just ask me where do I tend to aim, is minus 125, minus 150.
And look, I'm very similar, but because the majority of our patients are cataract, the whole idea of testing dominance just disappears.
Yes.
And I can't say, I struggle to think of cases where I've burnt my fingers at that level of myopic defocus, as opposed to some disruption of your binocular system, like monofixation syndrome or previous strabismus. I won't touch them.
Sure.
Or if I'm talking to the patient and I can see they're not really understanding, conversation ends. But otherwise, I'm very happy to ignore dominance at that level, particularly with EMV. I think what people perhaps fail to recognize that, yes, the positive spherical aberration leans towards near vision. It's not symmetrical. It gives you more reading. Better than negative, which is a mirror image, but it's leaning towards distance
Yes.
or hyperopia. It's not much use. But it's also got significant on the other side too. So when you use it bilaterally, your distance eye is leaning towards near, and your near eye is leaning towards distance, and you get that lovely blended vision.
Correct.
To some extent, I think we've done a disservice by calling it even modest monovision, because it's binocular vision, and you can show that because when they've got it and you look at the chart and you shut one eye, shut their near eye, and they won't read quite as well. And when they read, shut their distance eye, and they don't read quite as well. So they really do talk to each other. I mean, that was the reason I chose positive, because I knew it was compatible, particularly with monovision or some monovision, and is used quite widely to assist all so-called EDOF. I coined the term EDF, and it became EDOF, or now extended range. But there was a reason for it.
Sure.
Besides less sensitive to decentration, and just that waveform is really well suited towards modest monovision. Let's move on and talk about another aspect. To me, the other key of being successful with modest monovision, particularly a modest monovision with EMV, is eliminating astigmatism. So you're talking to an Australian, and we love torics. My practice, 85% have torics. I'd imagine doing premium lens surgery, you have to embrace torics. But I think I was reflecting on the other day, and I think with modest monovision, it's also very important that you eliminate astigmatism. Because, remember I said, if you've got sharp vision in one eye, you turn off the other one. But if you've left some cylinder and it's not so sharp, perhaps that automatic suppression doesn't work so well.
Yeah.
So tell me about the role of torics, EMV toric.
Sure. So I feel that in using premium lenses and trying to achieve spectacle independence, nailing the refractive target is key, no matter which lens you're using. And it's certainly the case for EMV, we're using monovision. So my tolerance for using a toric is very, very low. Generally speaking, half a diopter or more of corneal seal, I'll use a toric lens. My threshold used to be higher because I used to be frightened of flipping the axis until I learned a bit more.
Yes.
I was in a lecture given by Michael Goggin, and he reassured the audience that flipping the axis does nothing. No. So now I'm far more confident saying, okay, well, if it's a half and I'm using a 3/4 diopter toric, that's still much better for that patient. So yeah, I've got a very low threshold, and much like you, my percentage of toric lenses is above 75%, comfortably. Well,
I'll see your hand and I'll raise you one, because I'll do a toric lens when the K is of 44/44.
Okay.
Because I would never look at the Ks and make a judgment on that. I look at the predicted residual astigmatism. And if it has to be as close to zero as you can, and that means because of the multiple vectors, that even when someone's got no cylinder in their cornea, you do the toric calculation always, and then you make your choice. But Australia is quite unique. It's partly that the medical insurance covers a toric.
Yes.
So there's no discussion about cost.
No barrier.
You don't tell the patient you're doing a toric. It's just standard of care. So I understand we've got a fairly unique position. We're diverging a little bit, but let's focus on post-refractive.
Okay.
I had a great discussion on a podcast, Peer2Peer, with Dan Reinstein, and we really delved into the depths, because as you mentioned, Presbyon is similar in some ways in EMV and Darshak Patel. And I mean, I was always a bit cautious because I know myopic LASIK or PRK creates positive spherical aberration and RK, and so you're adding more. But I'm seeing a lot of people use EMV successfully for myopic LASIK. Hyperopic LASIK, I understand, because if anything, you would say positive makes more sense in that, in that context. But even for myopic LASIK, and Dan was saying, as long as you don't have too much,
yes,
you're adding on another 0.15 or 0.2 is not going to detract, but just add a bit more reading. And I think Darshak presented a paper at ESCRS on a number of cases where he had done just that. So I'm fascinated to hear on your approach.
It's very similar for the main reason that I worked for Dan for 4 years. And so my teaching comes from that. And so my approach is pretty much identical in that what I'm looking at is what the patient is bringing to the table beforehand. So for any patient that I'm going to use an EMV, I will look at the corneal spherical aberration for any patient. Now, if they're a virgin eye, most of the time, you're not going to have to worry, right? But if they are post-LASIK, then it's going to have shifted the needle. And if they've had hyperopic ablation and they've been driven negative, if I give them an EMV and bring positive to that, my concern is that I may move them towards zero and reduce some depth of field. So I may not use that. I may use a neutral lens, or I may use a negatively aberrated lens to try and push it further. It's all about trying to hit the sweet spot and being mindful of a therapeutic range and then a toxic range, and not treading too far towards the toxic. So for the myopes, again, it's looking how far positive have they gone, and can I use an EMV to take it further, or do I not need to? A lot of the time I might say, well, they've got enough on their cornea, and I can use a spherical aberration neutral lens and just utilize the benefits that they've already had from their laser eye surgery.
I think that's a sensible approach. I mean, if it's a fairly recent LASIK PRK and you look at the topography and it's a nice big broad blue zone, you probably get away without measuring, but there's no harm in measuring. It makes sense. And you can't do modern cataract surgery without topography.
Absolutely not.
So you already have an instrument that you can look and take the trouble. Interesting with Dan, though, was he defines spherical aberration as 6 millimeter on the cornea.
Yes.
But in terms of lenses, that's not what we tend to do. We measure it actually aberrometry or something. And so, when he said, he's quite happy to do EMV when it's 0.4 plus 0.4 spherical aberration, and I raised my eyebrows, but he's talking in terms of the cornea at 6. Doesn't always translate.
To what? Exactly.
So we made the point, which really defined how we're measuring it.
It's a difficult thing to compare, isn't it? Because we're not always measuring apples and apples.
No.
A lot of the time.
No. I think for the normal patient, average patient, you really don't have to measure.
No, I think you could argue that, and that was what drew me to the EMV to begin with, because knowing that the standard deviation is around about an average of 0.2 positive on someone's cornea, you know that generally speaking, you're going to be fine.
I mean, I think that's one of the advantages of EMV. It's positive. We all have positive spherical aberration.
Exactly.
But like anisometropia, we know how to suppress, and we live with positive spherical aberration. There's very few people who have negative spherical aberration on their corneas. And I'd be more concerned about making someone negative than I am about making them positive or a bit more positive. But you've probably used more extended depth of focus. I don't like the term. It's such a heterogeneous category. There's all sorts of optical principles.
100%.
But let's use it. And have you had experience with negative? I mean, almost all the others are negative. I'm not talking about the ones that just manipulate spherical aberration to make it negative. But if you look at some of the diffractive principles, they manifest as negative. If you look at lenses which have really lots of different principles, like an annular ad, I won't mention names of other lenses, but if you look at them on a wavefront, they're negative. So what's your experience on other EDF lenses? Let's use EDF.
To be honest, I haven't used a huge amount of them for the reason that I favoured the positive, and that's what drew me to the EMV. I have used negative aberrated lenses in post-laser patients, as we discussed earlier, to try and move the needle more negative. But generally speaking, I've avoided it because I've assumed the idea that a virgin patient brings positive spherical aberration to the table and I want to push it further, not move it towards zero. So I haven't used a great number of them, Graham, to be honest.
Yeah. No, I'm interested. I mean, I stay clear of it because if you're negative, you're very sensitive to not being perfectly centered.
Sure.
And we never center a lens perfectly. We don't know where the center should be anyway. So I've also stayed clear of that. You've been very successful with EMV and you've used it widely. And I understand that that includes considering friends, family.
Absolutely.
So can I ask you whether you've actually used it in the family?
I have. I've used it for multiple friends and family now, but probably most importantly, my father. So my father developed cataracts 2 years ago now. He approached me asking if I would do his surgery. It's a little bit debatable as to whether that's approved in the UK. I asked our regulatory board and they're not allowed to tell me that I can't do it, but they kind of strongly phrase their reply of please don't. Yes. So I asked a colleague if they would do the operation, but highly recommended that he have an EMV. So my father, I'm not sure how familiar you are with the north-south divide in the UK, but in the north where I'm from and where my father's from, it's quite a stoic population, yes. Not tend to be motivated towards glasses independence quite as much perhaps, and so he certainly wasn't. It just was not in his consideration that glasses independence was something that was motivating him. He just wanted to see better. He was struggling with glare at night when he was driving, and so he wasn't interested in multifocal. To a certain extent, he wasn't interested in monovision because, again, it wasn't something in his consideration. He just wanted to see better. But I said if he had an EMV at plano in each eye, he had nothing to lose. He'd get all the benefits of a standard monofocal and some, and not have to worry. And so what it's given him is 20/20 unaided distance. He loves the fact that he can see nice and clearly now when he's driving, but it's given him some useful intermediate and some useful near. So if he's in good light in his conservatory reading a book, he can manage for 10 minutes, 15 minutes. Sure, if he goes to a restaurant and it's dimly lit and he's trying to read the service charge at the very bottom, he has a pair of weak readers. But it's given him a complete new lease of life, and so much as he's far less dependent on glasses than he was before. He will say that he can leave the house, forget his reading glasses and not go back for them because he can make do. He can make the font bigger on his phone. And so that's given him a total new lease of life. I have absolutely no regrets whatsoever.
Well, you've made my trip to the UK worthwhile to hear that story. I mean, and it reminds me what I love is that those patients where spectacle independence is not on their agenda, sure. When you give it to them,
yes,
they still love it.
Absolutely.
And also your story tells me something else. And for the criteria of success, we often put down total spectacle independence. For many publications, that's a criteria. Yeah. And it's a very poor criteria because the need to use spectacles occasionally for that small print never fusses anyone.
Yeah.
And but they don't want to be totally spectacle independent. They want some of that freedom. And yet you've got that insight and I share it. But I don't think it's as widely understood as it should be.
And it's difficult, isn't it? Because it's very difficult to measure happiness and satisfaction, right? Because that's the real measure when you're sat in front of the patient. And as long as you set the boundaries of expectation beforehand and are realistic, then that's what my dad is. He is extremely happy with the result. Sure, he has to wear readers on occasion, but he knew that before. And actually, because of how we counsel him, he's actually wearing them less than he thought he would. Yes. So he's extremely happy for that reason.
Well, it rings a bell with me, maybe because I was actually born in the UK and lived in Leeds. So maybe I'm from the north.
We'll make you an honorary northerner then, absolutely.
Look, any questions you have for me, Alastair?
Absolutely. I mean, firstly, thank you for coming to visit us here at Optegra. It's a real pleasure to be involved, a privilege to be on this side of the interview. I think it would be remiss of me not to ask some things from you, because I'm sure the people listening far more want to hear what you say than what I say. But I guess it's the opportunity to ask you about the concept of the EMV and how you came to come up with the idea. Were there any particular eureka moments, and how did it eventually come to fruition? What was the journey like?
Look, it was a long journey, and it extends, as I indicated, back to using modest monovision and realizing I could only do so much. I could do a lot. I could make people very, very happy. but I wanted a bit more. And I thought, how can I get more without losing something? And I realized it's all about what you target. And so the first thing was, what about just stretching out the vision? It was before the other extended depth concepts. And I had a choice, and I looked at diffraction, and I looked at pinhole, all other mechanisms, and decided that positive made the most sense.
Okay.
And then I had to find a partner. And if you've done any innovation, you realize how difficult that can be. I won't describe the entire journey, but I'll describe the end destination, which was a partnership with Rayner. And that's really been a very gratifying experience. You've probably worked with them, and quite a unique company that it embraces innovation from outside. That doesn't always happen. And I was very fortunate because, to have a great idea is nice. We all do. But to be able to make it real is not common, extremely satisfying. And, I'm grateful for that opportunity. But that's really the story, trying to maintain quality of vision. It's a space which I'm very happy to be in. We're having discussions about, well, can we extend it a bit more? And yes, you could, but do I want to? No, I really enjoy the space. I see it as getting something for almost nothing. It's very hard to demonstrate. And when I did the first EMV, and I said it was over 10 years ago, I always thought, well, look, I'll use this in the reading eye and I'll maintain the distance eye for best quality.
Okay.
And I think I did the first case on a Monday. And by the end of the week, I changed my mind because I saw how good the vision was. I saw that it was real. I was getting more, but I saw that I'm, in the 6.5 plus range, not what I expected. So the next week it was in both eyes. But that's really was that journey. And it's a great journey, but the pleasure I have is talking to someone like yourself and you sharing your experience and some of your success with that lens.
Well, thank you for doing it, because it's made a big, big difference to my practice and, more important, to my family. So thank you very much.
Well, thank you for sharing all those thoughts and all those insights.
My pleasure.
And I hope the readers have enjoyed this edition of Peer2Peer.